Asmita is going to talk on corneal masquerades, more than what meets the eye. And then next is Mamta.
Good evening, everyone. This talk was supposed to be for the beginners in cornea or juniors, but it looks like I'm the junior most here. So I feel privileged to be a part of this historic AIOC midterm, and I thank the AIOS Scientific Committee for this opportunity. So the next 7 minutes, I will introduce you all to some corneas who came to me with a mask on, and to an extent was successful in fooling me until eventually I unmasked and saw the real face. So I will introduce you all to them, so next time they come to you, you know the real face already. More than what meets the eye. After all, no one can wear a mask for very long. So this first cornea who was referred to me for further management of peripheral ulcerative keratitis. Yes, it looks like PUK because it's peripheral, circumferential, and patient did give history of recurrence. But there was something unusual about it. The extreme periphery near the limbus, where there should be thinning, was spared. In fact, there was thickening, there was limbitis. The nasal area was normal, the other eye there was no evidence of thinning, but still it erred more on the side of PUK, so I started the patient on topical steroids, cycloplegic and lubricants. I was happy on day 4 when the patient was symptomatically better, the congestion had significantly reduced, the edges were now sloping, epithelial defect appeared to be healing, but the autoimmune workup came negative. 2 weeks follow-up, I was on cloud 9 because the original lesion had almost healed, the epithelium defect had healed, but inferiorly there was a circumferential extension and there were keratic precipitates. I referred the patient to immunologist considering that it was worsening of PUK, and then the patient comes back to me with this picture on immunosuppressants. Impending perforation, significant worsening. I planned a glue BCL and microbiological workup, but as a routine I stained the cornea. And there was a large geographical ulcer staring at my face. So this was a case of HSV keratitis. When managed with antivirals, I deferred the glue BCL and the patient did extremely well, with a lot of astigmatism though. The second case, which came with a mass lesion on the cornea, I didn't know what it was. I thought it could be a keloid. OSSN was one of the DD, but unusual because it was a very uniform, smooth surface. I thought of exploring. I planned a superficial keratectomy, but when I took the patient on table and I just held this lesion in the forceps, it came off the cornea just like a sticker-on, or as easy as peeling a BCL. So this was a case of chronic pseudophakic bullous keratopathy, and this was epithelial hypertrophy which was confirmed on histopathology. We could also see some old enterostomal puncture marks on the cornea. Patient was totally asymptomatic for all these years because this mass lesion was, it was acting like a bandage. I did a DSEC and he's doing fine. This third case was referred to me for therapeutic keratoplasty. The referring surgeon thought it's a limbus to limbus corneal infiltrate. So this white thing it's not into the cornea, it is on the cornea if you have a look at it. Within few minutes, this is how the cornea looked. All that I had to do was patiently peel the plaque off. So this is a case of fungal keratitis with a dense plaque, which came KOH positive. Patient did very well on antifungals and there was no need of therapeutic keratoplasty. This fourth case was referred to me with a bandage contact lens as a case of worsening superficial keratic infiltrates. I saw the patient was happy, he was symptomatically better, already on antibiotic lubricants. I said, let's just observe. When the patient came back to me later, this was the picture. It looked different, some weird pattern, but these infiltrates were more superficial than it should have been. And on careful observation, they appeared to be moving with each blink and moving with the BCL. All that I did was remove the BCL and they were all gone. Few were sticking to the epithelium. So basically they were the deposits under the BCL that gave an impression of superficial corneal infiltrates. And this last and most interesting case is a 30-year-old young man who came after 2 months of injury with a sugar cane. He denied any history of eye surgery in the past. So it looked like a lamellar corneal tear which had healed with it was stain negative, the epithelium had grown over it. But there was this trapped lesions which I thought it's either a foreign body or an infiltrate or some trapped debris. On slit lamp, again, it looked something unusual. If it was just a lamellar flap, I couldn't figure out why there was so much of interface scarring, and it looked thicker, but it didn't look like edema. I wanted to start on steroids, so plan was to open up the flap, wash it, and start him on steroids. So just as I started, and I wanted to access those foreign bodies, I couldn't reach them. There was something stopping me. I was struggling to reach till them. This was under topical anesthesia, and the patient suddenly moved his eye down. Yeah. And I thought I have worsened this because there was a significant extension of the thing, but it is too uniform circumferential. Does it look like a LASIK flap? Then I asked the patient, have you undergone an eye surgery before? He says no. I specifically asked, have you undergone a laser procedure before? He says yes, at the age of 18, because he wanted to enter army, and so he tried to get rid of his glasses. So the debris I was talking about was epithelium, and the epithelium had grown all over, on the stroma, under the flap. I tried all the means to get rid of it, scraped it, hand-picked it, and then finally I left it to mitomycin C to take care of the remnant cells so that there will not be any epithelial ingrowth in the future. Okay, I can forward this video. So post-operatively he did fine. So things are not always what they seem. The first appearance deceives many. The intelligence, rather in our field I would say it is the experience of a few, perceives what has been carefully hidden. So don't get fooled. Fluorescent is our best friend. Always stay in every case, even if you think you know the diagnosis and you know what's happening. Trust your instinct. When you feel something is unusual, keep an eye on that eye, document with clinical photographs, and ask the experienced few. Because, and thanks to WhatsApp, that seniors and experienced people who must have seen such cases which is new to us, they can spot on say that, okay, this is this and this is that. So they are very nice and accessible. So don't hesitate to ask your seniors or share your cases and ask what it is. That will save a lot of time and will do good for the patient. Thank you for your patient listening.
Excellent cases, Asmita, really amazing, excellent cases. And you've shown that it can always be sometimes simple and often surprising. So we'll go to the next presentation.
So I think in all these cases, yeah, can we have the next presenter? Meanwhile, next one, Doctor. Dr. Mamta. So I was just saying that all of these things, like the LASIK flap one, and even that it looked like a drug deposit but turned out to be a fungal plaque. But I think all these cases, it is imperative and it will be useful if you do an anterior segment OCT. So it will give you some idea, like the flap one, I'm sure would have been picked up if the ASOCT was done. But it didn't show the flap. Okay.
sometimes OCT you need to get serial scans or do it yourself or be with the technician and write from one to the other. When you see something and you not explain. And the earlier case with the pseudobaby, with the epithelial hyperplasia, so that would definitely have benefited OCT. You'll see a very clear plane, so you know what it was before you go in. But nevertheless, very well managed. Dr. Gupta, please.
Yes, ma'am. I will just have my slides and then.
Ask him to
Go back.
You have loaded your presentation on that?
Yes, ma'am, I have already loaded it. It was there.
Who's the audio visual person? आप देख लो ज़रा.
Go to day 1. Good evening, everyone, and thank you for this opportunity. I will be talking about the roles of tissue adhesives in perforated corneal ulcers. I can't move the slide, okay. Perforated corneal ulcers are ophthalmic emergency, and the primary aim here is to maintain the ocular integrity. We are not talking about visual gain here. And we have multiple options like tissue adhesives, Tennant's patch graft, keratoplasty in the form of partial or full thickness graft, and conjunctival flaps. But what we will be talking today are tissue adhesives. Tissue adhesives can be used in two manners in perforated corneal ulcers. They can be used as a primary sealant, or they can be used with other biological tissues. And the important point before they are used to consider is the size of perforation and what is the basic etiopathogenesis. Mainly we have two types. One is synthetic, another is biological. Synthetic, we have N-butyl 2-cyanoacrylate, which is readily available, less expensive, easy to use, but they are not biodegradable. They cause foreign body sensation and they induce vascularization. On the other hand, fibrin glue are biocompatible and biodegradable, but their tensile strength is less, and as they are blood-derived product, there is a chance of transmission of prion or viral diseases. So if we talk about cyanoacrylate, it polymerizes rapidly over the corneal surface, and the peak bonding strength is seen at 2 minutes. In addition, it stops stromal melting, and it has got bacteriostatic property against the gram-positive. If we talk about the clinical application, then it is best suited for corneal perforation or corneal ulcers which are concave in profile. The reason being, tends to form a mass over the surface. And ulcers located away from the limbus, because over the surface of conjunctiva, the adhesion of glue is compromised. Mainly we have 2-3 techniques of application. One is direct application with 30G or 2060 needle, another is with the applicator like Merocell sponge, and next one is the glue and patch technique. So if we talk about the application pattern, so before applying the glue, we need to remove all the debris and dead cells from the surface. And what we will see here in this video, usually we should use the back surface of the Merocell sponge. But here we are seeing that in desperate measure probably, the cotton portion has been removed and that is being used, but this can put threads over the ulcer surface. So even if we have to use the cotton bud, better to cut it in a half, or just cut the cotton part and then make sure that it is a vertical cut, not the oblique cut. And then it just works. I can't. No, go back to, yeah, thanks, Sam. So just wait, see, once it polymerizes partially, see if required, go ahead and redo the gluing. That is how, and at the end, just put the BCL. The next one is the patch technique. This video is not mine. Mainly we cut those small plastic drape from a surgical drape with the help of dermatrifine. Then we take any ophthalmic ointment. We use this ointment to stick this plastic disc, then we dip it in the glue, and then we put it over the surface. After clearing the surface, I mean removing all the debris and dead cells, then only, the way we do it in the usual manner. The third is the 2060 application, and this is something which I use only in cases of PUK when we have sufficient gutter, because at times it's not completely under control as we do it with the help of Merocell sponge. Can you again, excuse me, cursor? Yeah. So here we can see, as soon as we are putting the glue over the surface, it is polymerizing. It's not giving us even a second or two before it polymerizes over the surface. So this was something new to me, and when I cross-checked the expiry date, the date which was written over this box and what was mentioned here on the leaflet, these two were different. So this is something we can keep in mind for the next time use. There are certain special clinical situations, like if the aqueous is free flowing through the corneal perforation, we need to put a temporary tamponade like air bubble. If the iris tissue is plugging the perforation and if we put the glue over it, it's going to cause intense inflammation. So one way is to like swipe away the iris and then put with OVD or air bubble and apply the glue. What I follow, I put a plastic drape, apply the glue, put the plastic drape again, and over it put the BCL. This is the Duas technique. For the defect larger than 3 mm also, which it has been used, I do not have any clinical experience with that, but one can put a mesh of 10-0 nylon suture and over top of it one can apply the glue. So the question arises when to remove the glue. Usually I leave it for 6 to 8 weeks, and one clinical tip which helps me, I just gently give a, try to nudge the contact lens, and if the glue moves with this, that means the underlying epithelialization has occurred. So we can safely remove it after that. Fibrin glue works on the principle of clotting, the normal blood clotting, and mainly we have two brands. One is from Tissel, another is Relisil. Glue preparation I'm going to skip here. For defect up to 2 mm, it has found to be as effective as cyanoacrylate. For defect between 2 to 3 mm, cyanoacrylate appears to be superior because of its higher tensile strength. Fibrin glue with other biological tissue is always a welcome thing, especially in cases of compromised ocular surface, when we have like cases of Sjogren's, when we can use the biological property of amniotic membrane. So this works well in smaller perforation, which is mainly away from the visual axis, because this is going to cause a scar and compromised ocular surface, as I said. Tennant's patch graft, it regained its popularity in COVID era because it's an autologous tissue, causes minimal reaction and vascularization, and it is cost effective. This is a very old video. This was a patient with no PL, and this patient had a perforation here after healing of fistula, I should say, after healing of a corneal ulcer. So we just, we did the blunt scraping of this pseudopterygium. We took a bit of Tennant's, put it there with the help of glue, applied a multi-layered amniotic membrane, covered the defect also, and the entire area we covered with the amniotic membrane. And this is the final picture after healing. Perforation held well here. So if we have a perforation less than 2 to 3 mm, then tissue adhesive can be used as a primary sealant. They can be used with AMG with fibrin glue or suture, or can be used with Tennant's patch graft. We can use in there. For perforation larger than 3 mm, better to go for Tennant's patch graft or corneal patch graft along with tissue adhesive and sutures as such. Thank you.
That was a really excellent overview of tissue adhesive. I think we'll go to the next. Arvind is also here, and there's Dr. Gautam, I believe, right? Dr. Gautam is here as well. So maybe we'll finish with, we'll go to Dr. Gautam. We managed, I think he's got your presentation. Then we come back to Arvind. Okay. Hi. Everybody's here. Good, good. So Dr. Gautam is speaking on penetrating keratoplasty, a closed chamber approach. So after we finish with Gautam, then we go back to our missing candidates who are now appeared, Arvind and also Rishi, right? Yeah. I know.
Good evening, everyone, and I would like to thank for giving me the opportunity. So I am going to present penetrating keratoplasty triple procedure, a closed chamber approach. So corneal opacities with cataract, if both these coexist, then the approach may be either simultaneous cataract as well as penetrating keratoplasty, or we may go for sequential. For sequential, even we can go for keratoplasty first and then followed by cataract, and there is a lot of good thing like IOL power calculation accuracy will be there, and closed chamber approach can be there. But the procedure will take 2 sittings, and there is delayed visual rehabilitation, endothelial compromisation, and procedures, since 2 procedures so expensive also. So we can go for cataract first and then keratoplasty. So definitely we get a closed chamber approach, but since there is poor visibility, complication rates were high. So one option is simultaneous, where we perform cataract with IOL implantation with penetrating keratoplasty, and this is especially best for elderly people, where expenses and inconvenience of two procedure should be avoided. So basically, sequential versus simultaneous procedure is actually a difference between the closed chamber versus open sky procedure. So there are a lot of challenges of open sky procedure, like rhexis making is very difficult here because of the high positive vitreous pressure, and is same with the cortical cleanup, because vitreous pressure blocks the capsule, and in-bag placement IOL is also difficult, and followed by a lot of complication like expulsive hemorrhage and all. So how can we overcome these complications? So one tip I would like to give, that you just lift up the speculum, and as you can see in the video, your vitreous pressure will be minimized, and you may implant IOL, or even you can make rhexis comfortably. So this can be a tip. But what happens if you convert this open sky procedure in a closed chamber procedure, and will get all the advantage of closed chamber surgery? So here it is possible in certain cases, like this is case where there is peripheral adherent leukoma, so no doubt we will go for penetrating keratoplasty here with a lamellar central scar. So in such type of cases, we can try this closed chamber approach, as I am showing here. So this is the case where I first took the measurement to decide the size of trephination, central mark, and then did trephination with appropriate size, followed by anterior lamellar resection. Fortunately, I could not land up with the perforation because the scar is thick. I removed another layer because there is enough thick stoma was there, and you can see the now I made the ports at the graft house junction. So this thing is done before also, but I tried this here because there are certain advantages I would like to discuss later. Followed by staining of capsule, synecholysis was done, both anterior as well as posterior synecholysis was done. And since pupil was small, I used these iris hooks, and you can see here I made this rhexis as comfortable as I could do in closed chamber surgery. Followed by hydration, which is even very smooth, followed by rotation, and then I made another port for second instrument. And you can see I could perform phacoemulsification as usual. Nucleus rotation is also very good. Ports, though ports are slightly leaky, so you may need to raise your bottle height also. But it is possible, as you can see here. Now, while irrigation aspiration, especially since your port is big, the main port, so it leaks very, very much. So even you can suture these ports also while you do cortical cleanup. Then I put this foldable IOL in the bag by this approach. And then I resected the graft as usual. Then I removed the remaining residual posterior lamella. I excised, and then I sutured the graft as we can do in our routine penetrating keratoplasty. So as I would like to mention here, I made a port at graft house junction. So this is in this case we need a intact periphery, and we need not to put additional suture to the ports because we are making entry at graft house junction. And there is no traction while graft suturing. Like as you can see here, there is traction by the peripheral suture. So this will make your subsequent suturing difficult. So I would not like such type of suture traction. Second thing, since the ports are very leaky here, so in that case you can raise the bottle height to minimize this process. So and post-operatively you can see that central circular pupil with stable in-bag IOL with mild corneal edema. So another advantage of this procedure that we can learn, because this anterior lamellar dissection, it mimics the DALC, what we do in DALC. So one can practice lamellar surgery simultaneously. So this is another advantage of this approach. So to summarize that, triple procedure is advantageous in elderly people. Phaco can be done if visibility improves after anterior lamellar dissection. So, and can get all the advantage of the closed chamber surgery like precise rhexis, better cortical cleanup, and in-back placement IOL with optimal stability. So thank you, your patience listening.
Thanks a lot, Gautam, for a very nice coverage and very nice video. Really liked that video. We have with us now Dr. Arvind Kumar Maurya, who will be talking on trehalose, a new and novel autophagic bioprotectant in the management of dry eye.
IT, kindly connect it.
Some very nice tips you gave, Gautam. Very small, but some very, very lovely tips you gave in your talks, and that was really very nice. I appreciate it.
That patient with adult glaucoma with significant cataract, patient would have left without any PK. After surgery, after cataract surgery with IOL implantation, he should get good ambulatory vision. If the person is very old, he can do their routine work.
Miss, you can leave after removal of anterior lamella.
No, that actually.
Only the cataract surgery, and we can leave that part of PK.
Definitely, that is possible in certain cases like old debilitated patient, you can do cataract only. Such if you have clear more than 50% are about
Relay नहीं आ रहा इसमें.
clear cornea, then you can
Relay is
do
not.
cataract only.
Because one-eyed patient, elderly patient who is coming from very remote area, they don't get this opportunity for frequent visit to the hospital, and any PK can lead to
Full
any
screen नहीं आ
complication
रहा.
at any
Okay,
point of
ठीक.
time. So this may be one of the options leading.
Yeah, absolutely. You have to judge depending upon the type of patient, whether he can come for follow-up, what kind of opacity is this. So all these factors are there, and the management can vary depending upon the type of patient. Yeah.
Just patient expectation.
True.
If one eye patient, other eye is
True.
not good, then we can go for cataract only
Yeah.
to make ambulatory.
Okay. Thank you. So, Dr. Arvind Maurya, please.
Thank you. So, I will be speaking on trehalose, a new and novel autophagic bioprotectant in the management of dry eye. So, as we all know that dry eye is a multifactorial disease of tears and ocular surface, and it causes discomfort, visual disturbances, and tear film instability and damaging the ocular surface, and the incidence is of 5 to 50% all over the world. Prevalence is seen more in females, especially in the age group of more than 45 years, and recently increased dependence on the digital devices further increases the prevalence of the dry eye because of the incomplete blinking leading to tear film instability. And so, multi-pronged approach for treating the tear insufficiency, lid abnormalities, and ocular surface inflammation and dietary changes and environmental modifications are much needed. So there are already so many topical drugs available like the CMC, HPMC, HBGOR, sodium hyaluronate, and now trehalose in combination with the existing lubricant, that is sodium hyaluronate, is a naturally occurring disaccharide, has proven to improve tear film homeostasis and benefit patients of dry eye disease. So what is the mechanism of action of this drug? It increases autophagy. It protects the cultured human corneal epithelial cell membrane, and it prevents cell death from desiccation and preserve normal cellular morphology and functions of cell membrane and their proliferative activity. And at the molecular level, this new kid on the block works as cryoprotective agent by preventing crystallization of protein hydration water. So what has been clinically done and what different we did? So there are many randomized clinical trials. Most studies, they have inadequate sample size or patients were not followed for long enough time. And only Chidambra et al., they evaluated more than 100 patients. So we planned this randomized control trial with highest sample size in all worldwide studies. So participants were the 15 to 74 age group, coming to the ROPD, complaining of dryness, watering, grittiness, burning, and hyperemia. OSDI of more than 0.9, shimmer of less than 10 millimeter, T-but of less than 10 second, and patients with chronic drug intake were also included. Exclusion criteria were prior ocular surgery, any previous ocular lubricants, use of anti-glaucoma medication, and then randomization was done. And clinical assessment was done by doing the OSDI questionnaire, 0 to 12 normal, more than 13 to 22 mild DED, and more than 23 to 32 moderate, and more than 33 were treated as severe dry eye disease. And then shimmer test, T-but, and Van Bisser's conjunctival staining score was done, and patients were followed on 4th and 8th week respectively. So these were our results. Female were 59% and male were 41%. And when we compare these shimmer test values in the VOS eye in eyes receiving 3 halos versus the standard therapy, so from the baseline and at the end of the 8th week, there was a clinical significant p-value between the 3 halos group, and 3 halos proves better. And also there was a significant p-value difference in comparing the tear film breakup time. So again, 3 halos fares well. But when we compare the tear film height, so it was better in the 3 halos group, but there was no significant p-value difference in both the group. And it was same with the Van Bisser's scoring, and it was same with the comparison of the OSDI scoring in both the groups. So the Chambera et al., they said that the this sodium hyaluronate 3 halos is effective and safe with better patient satisfaction than the existing sodium hyaluronate alone. And in our current study, we found that the sodium hyaluronate 3 halos led to greater improvement in the shimmers value and the tear film breakup time, although the other the parameters were same. So merits of our clinical study, we had the largest sample size, worldwide data, and a strict adherence to randomization and masking protocols, and relatively long follow-up period. Demerits, lack of use of more sophisticated tools for tear film assessment, which might influence the subjective OSDI score. Thank you so very much, and it recently got published last year only.
Thank you, Dr. Maurya.
Thank you.
Trehalose is a polymer which is really, getting more and more popular, and some good results have been seen in some of the studies. So nice.
Yeah. It's also very effective in the digital vision syndrome patients. It's very good.
Thank you very much.
Thank you.
So we have 2 more talks left, and one is by Dr. Rishi and one is by Harsh. So Rishi has ocular surface management before surgery. So since Trehalose was presented, maybe in continuation we can have him, and then we can have the corneal neurotization, which is really an upcoming topic. Yeah.
Good evening, everybody. I am thankful to AIOCMTC Scientific Committee for giving me this opportunity. My talk is on ocular surface management in cataract patients. Ocular surface disease is more common in elderly individuals that frequently require ophthalmic surgery that further compromise the ocular surface by injuring the epithelium, sensory nerve, disrupting the tear film and causing the further local inflammation. And ocular surface disease can be broadly classified either in a non-visually significant or visually significant. In non-visually significant, surgery can be proceeded as planned, and we should counsel the patient about the potential for worsening after the surgery. But in visually significant ocular surface disease, it affects the preoperative measurements like topography, keratometry, refraction, aberrometry, and which affects the potential post-operative surgical outcome. So in this type of visually significant OSD, we should sufficiently treat these conditions prior to surgery, convert them in non-visually significant, and then proceed with the surgery. Because failure to manage ocular surface disorder can lead to the unsatisfactory vision, worsening of the symptoms, and it can also cause the infections like the endophthalmitis. So medical management of the OSD prior to ophthalmic surgery is very important. And among all the OSD, dry eye disease is very important. Patient may present with the blurry or fluctuating vision, so we should treat the dry eye effectively before the patient has any type of refractive or cataract surgery. Although most patients with dry eye may be asymptomatic, 87% of the cataract surgery patient become symptomatic after the surgery. Dry eye disease or OSD affects the topography, biometry, keratometry, higher order aberrations, and it causes the disappointment in the post-operative outcome. Even the cataract surgery also causes dry eye via the various mechanisms like the use of topical eye drops with or without preservative, phototoxicity, intraoperative sterilization with the povidone iodine solution, transaction or denervation of the nerves, increase in the inflammatory markers, and the loss of the goblet cell density. So dry eye adversely affect the outcome. So in the preoperative period, we should diagnose and manage the dry eye disease. For the management point of view, sometimes the preoperative diagnosis, patient history is very important. Patient may give the history of grittiness, discomfort, blurry vision, fluctuating vision, or there may be history of some systemic collagen vascular disease. So we should look out in the preoperative period. On the clinical examination, you can find the debris in the tear film, a low tear meniscus height, evidence of the lid margin disease. On performing the fluorescent stent, we can find out this SPKs or superficial punctate keratopathy that we can miss in the normal slit lamp examination sometimes. Corneal sensation, especially in a diabetic patient, there may be chance of persistent epithelial defect in the post-operative period. So in the suspicious patient, we should look for the corneal sensations also. And in the management point of view, because of the elective nature of the cataract surgery, surgery can be postponed till the surface can be optimized. And for the surface management, artificial tears are very important. Nowadays, especially cyclosporin can be used in the preoperative period because it decreases the chance of steroid-induced side effects. In cases of the aqueous deficiency dry eye, after controlling the ocular surface inflammation, we can use the punctal occlusion. Another ocular surface disease which is very important in the cataract patient is the meibomian gland dysfunction that causes the evaporative type of dry eye disease. Even the epithelial basement dystrophy can cause irregular astigmatism and the blepharitis. That also affects the increases the chances of the ocular inflammation and increases the chances of the infection in the post-operative period. So management of the lid disease in the preoperative period is also very important. It starts with the eyelid hygiene. Topical azithromycin decreases the chances of the signs and symptoms of blepharitis, and in severe case of the flactellus or severe conjunctivitis, topical antibiotic steroid can be used. Even sometimes use of tetracycline at least 1 month before cataract surgery can be done, and omega-3 fatty acid is also beneficial in the management of the lid diseases. Even after the post-operative period, management of the ocular surface disease is also very important in the especially artificial tear solution. We can use preservative-free or eyelid cleansing should be continued. But in the patients with the surface disease, it is best to stop or taper the medication when it is no longer needed, especially topical NSAIDs. In the cases of the epithelial breakdown, theoretically it increases the chances of the corneal melt. So in conclusion, the overall goal is the preoperative ocular surface disease management include reducing the inflammation, resolving infection, improving pathology, stabilizing the tear film, and easing the symptoms before the surgery, which increases the likelihood of the positive outcome. Thank you.
Thank you, Dr. Rishi, and it's really very essential to treat the ocular surface, particularly wherein you are planning to implant a premium IOL, the multifocals and the EDOFs, etc., wherein the results may be adverse if the ocular surface is bad. Yeah, we would like to have a very interesting topic now, and that is by Dr. Harshvardhan Ghorpade, and that is on corneal neurotization. So let's see what all experience he is having with this interesting topic on corneal neurotization.
Third.
Yeah, it's there, open it.
Tisra. PPT. Yeah, thank you, Dr. Rajesh. It was, thank you for the invitation and the opportunity. And Good evening, everyone. I'm Dr. Harshvardhan from Navi Mumbai. Today I'm going to speak on corneal neurotization, our experience in the last 5 to 6 years that we have been doing this. No financial disclosures. So this is one of our cases. It's a cornea sparing evisceration, and 10 years later the cornea is still clear in spite of the evisceration. So how does that happen? And that's because of the nerves which are still intact. So epithelialization, transparency, all are affected by the presence of corneal nerves. We all know these causes of neurotrophic keratopathy may be infectious, inflammatory, traumatic, neoplastic. And in diabetes especially, it not only causes dry eye because it affects the nerves directly, but it also affects the epithelial growth factor, which affects the epithelialization. While in herpes, it's mainly the viral proliferation that affects, not the inflammation. And post surgeries like PRK, LASIK, radial keratotomy, we have neurotrophism. And confocal microscopy plays a important role in monitoring the progress of the treatment as well as the disease. So there are various techniques of or neurotization of the cornea. Either you can use the supraorbital or supratrochlear nerve directly and invert it onto the cornea of the same side or the opposite side. But it's a fairly destructive process. It needs a large coronal incision on the forehead. But if you use the sural nerve, which is the medial cutaneous branch of the sural nerve from the foot, you can have better neurotization without creating too much of dissection. And it can either be used on the contralateral side, and if you have ipsilateral sensations prevailing, then you can use it on the same side as well. So this is the direct technique which was earlier used, and this is the sural nerve being used. We'll come to the case, case-based illustration. This is our case where patient presented with herpes simplex of one side, and she had perforation as well, and there was neurotrophic keratopathy, and the corneal sensations were almost zero, and the vision was maybe perception to light. And we performed a sural nerve transplant to the ipsilateral side, and this is the way we procured the nerve, which is this is the medial cutaneous branch of the sural nerve from the foot, and this is a surgery where this branch of the nerve is then used to neurotize the cornea. It is connected to the supraorbital nerve in an end-to-side anastomosis. The importance being to remove the nerve sheath properly and to connect the nerve fibers so that you can have the neurotrophic growth factors reaching the cornea. And then the fascicles are made, and they are then taken under the conjunctiva, and covering all the 4 quadrants is important, and then creating subscleral tunnels to reach the cornea. And then finally the conjunctiva is sutured as well as the wound on the skin. So this is how the preoperative picture was, and then later, 8 weeks later, we found cornea quite clear. The epithelial defect was no longer there, and the nerves had also grown on OCT as well as on confocal. So this is pre-op. This is 4 weeks later, the epithelial defect healing well, and 8 weeks later, it is completely healed. And this compares well with other studies also. The vision improved from light perception to 6/18 after 3 months. And the aesthesiometry scores also improved to around 50 from 0. And the various studies also compare well in the literature. It's not a very new surgery since 2009. And in terms of nerve growth, epithelial defect healing, sensation recovery, vision recovery, it compares well with our study. We can also use immunostaining to look at the nerves, as well as gene marker studies to find out to prove the presence of nerves growing into the cornea. Basically, the nerves affect the stem cell functions of the epithelium. That is why we get epithelial defects. So this is a study which shows that how the progenitor stem cells are dependent on innervation for them to grow. So it also affects neovascularization. So whenever there is loss of sensation, you will have neovascularization. This study shows how VEGF-A and VEGF-B play a role. VEGF-A is mainly for neovascularization and VEGF-B plays a role in neoneurization. So once you have the nerves growing, the vascularization automatically reduces. This was a case report which we published in BMJ, where we had shown that how the vascularization of the cornea had reduced significantly after we did the neurotization procedure. This is one of our first cases, which was probably the first in the region or the country maybe. And these are some of the cases which he had done, patients like farmers seeing after 5 years because the cornea cleared up after neurotization. And this was our IC at World Congress in Mexico. And these are the advances. Now we know there is a nerve growth factor available, Cinegermin, which also has the same effect. However, it does not improve the sensations. It only helps in healing the epithelial defect. And it is quite expensive. It's like almost 8 lakh rupees in Indian rupees. While the neurotization procedure is more like a direct or a definitive treatment as compared to the nerve growth factor. Pediatric neurotization also we have done. The difference is that we have specific landmarks for the sural nerve in the pediatric foot. The fascicles have to be properly placed in the sclerocorneal tunnels for them to grow. Thirdly, the assessment has to be done objectively, like decrease in vascularization, because the children are not that cooperative. And there is something called as magnetoencephalography, where we check EEG impulses, and we find that the impulses are taken up by an area of the frontal part, which corresponds to the supraorbital nerve. So it's like stimulating the cornea, but the sensations are picked up as if they are coming from the supraorbital area of the forehead, because it is connected to that nerve. So these are the magnetoencephalography images. Okay, Karuna. How do you, okay. And this is a nerve exoguard. I'll just finish quickly. Exoguard is a extracellular matrix which is available nowadays, which allows the nerve to grow through it. So it protects the sural nerve that has been placed under the skin of the forehead. And we also do endoscopic neurotization, where we get better visualization and faster surgery time to locate the nerve as it passes from one side to the other. And we have also tried robotic neurotization with the Da Vinci robot we have at one of our hospitals. And we found it to be improving in terms of tremor cancellation, precision, magnification, and lesser inflammation. But it of course has cost and time issues. So in conclusion, good recovery of corneal sensations, vision, and corneal integrity. It compares well with our 5-year experience since 2015, almost 7 years now. The mechanism of corneal healing is stimulation of limbal stem cells. Neurotization and neoneurization are affected by growth factors, and VEGF-B plays a major role. We have evidence on confocal, immunological, and genetic, and neurotization also inhibits vascularization, and the recent advances include pediatric neurotization, extracellular matrix protector, endoscopic and robotic surgeries. Thank you very much, and thank you for the patient listening.
Thank you, Dr. Harshvardhan. It was fantastic. Very nice study and very nice presentation.
Thank you.
Thank you very much.
In how many patients did you perform this corneal neurotization?
So we have now almost done around 25 cases. And it's been more like a multi-centric. We have visited various hospitals and done, and in our area we've done almost 11, and the remaining in various centers across the world. So we are gathering those data, follow-ups, and then maybe we'll come out with the results at various centers. So we have found that mainly the trauma cases, the tumor cases, the unilateral cases, herpetic cases, they do very well. The general cases like diabetes also do well. But congenital anesthesias and all, we had done one pediatric case with a DALC procedure in that. They have moderate results. I mean, although the epithelium heals, we are not sure about the sensations. So that's how we have found, and we'll, I think, come out with some data very soon.
Thank you. Very nice presentation.
What's the gap, isolating the sural nerve and then doing it?
Same day. I mean, we have a plastic surgeon doing the foot thing, and we have already started dissecting the forehead. So that's how it goes. Sometimes if the plastic surgeon is not available, we do it ourselves also. So it's like a very superficial now on the medial side. It can easily be, and it doesn't have any effect on the final, on the foot also. I mean, you don't have foot ulcers or anything after that because there is a lot of cross connection between the nerves in the foot, so they take over.
Thank you. Thanks a lot. So this ends the session, and I thank all the speakers and everyone sitting here. I thank you all for participating in this session. Thank you very much.